statistics. So I've been teaching statistics for many years. Actually, that's what I taught first. And statistics is like going to the dentist. Nobody wants to go to see the dentist. Nobody wants to learn about statistics. I'm not quite sure why, actually. I enjoy statistics, inevitably. I think a lot of it is just because it's something you have to do, right, when you're doing research, to include your statistics. But it's not something that everybody necessarily thinks is fun. So this talk will be a little painful for some of you, but it's a necessary evil. It's something you do need to consider, and I'll try and explain that to you in this talk to let you know why. Okay? All right, so the title of the talk is Transforming Healthcare with AI, Cost-Effective Screening for Cancer. So if you don't know what cost-effective is, don't worry, I'm going to tell you all about it. Now, there's the remote working? Okay, yeah, perfect. Then I don't have to walk over all the time. Okay, so this is work from a student of mine from France, actually. So she was an international student. Here's a picture of her receiving an award for this work. Yay! So Lolita finished this work just recently, about 6 months ago. Okay, so let's just talk. So this is a global health talk that I give. And what I'm talking about here is introducing you to the burden of cancer. I don't have to go into detail on this because we've already talked about it. And it's everywhere, right? So burden of cancer, we have to deal with it. The one I'm talking about today is breast cancer. I'll touch on lung cancer as well. As we discussed earlier in the week, breast cancer is one of the top for us in Canada. In India, it's close with cervical cancer, correct? Remember we went through that? But that's for women, that's the number one cancer. So how do you, what's the first line? So what we call first line in medicine, what's the first thing you do? Is mammography. Okay, that's the first test. In many countries, you have a screening program, okay, meaning that all women will have a mammography every so often. Typically, it's every 2 years. I don't believe that's the case in India, correct? You're paying for it if you are screened, but it's not countrywide. Okay, so the challenges are, in this case, what I'm presenting to you is Costa Rica. So I do a lot of research in Costa Rica. I work with the government in Costa Rica, the Ministry of Health in Costa Rica, and we're trying to, better deliver healthcare to a middle-income country. Okay, so Costa Rica is considered top end of a middle-income country. Now, what do we recommend? So 72 days interval between diagnosis and surgery is what's going on currently in Costa Rica. What's recommended by the WHO is 30 days. So you can see already the time between diagnosis and surgery is too long, right? And that's, and I'll talk to you about what that interval is. False negative diagnosis delays detection, and a false positive is costly, right? So what am I trying to say here? A false positive diagnosis is costly. So what do I mean by that? Anybody want to? Why is it costly? Why does it cost money if you get a false positive? Why does that cost the healthcare system? Because if you are identified as having a lesion in a mammography, it needs to be confirmed either by an ultrasound following or by a biopsy, or both. And both of those tests cost money. What's another reason for cost that maybe you don't think of? How would you feel if you were diagnosed with cancer? You feel good? Then you feel pretty bad, right? How long do you think it takes before it's confirmed that, oops, sorry, you made a mistake? At least a month? At least a month. So for a month, you think you have cancer. So that is a cost. Okay? And then we're going to talk about that. That is a cost. For instance, if you only want to talk about monetary value, how about the loss of productivity? She's not going to work as well because she's distracted. She may even stay home because she's so upset. So that's a loss of productivity. So think of it across your entire country. If the rate of false positive is high, you've got a lot of women that are very upset all the time. And that's a cost. Okay. So what is cost effectiveness? Cost effectiveness is really simple at a high level. Actually doing it, tricky. So it's the cost of the intervention in the numerator. It's a ratio. Cost effectiveness is a ratio. And then the denominator, it's the effectiveness of the intervention. Now in this case, I put what's here, it's called QALYs. Has anybody heard of a QALY before? It's not like a bear from Australia. That'd be a koala. QALYs is quality adjusted life year. Okay? It is a way of assessing the pain that someone's going to go through if they're misdiagnosed with breast cancer. Okay? It's what I talked about, I think, 2 days ago when I said, how much time would you be willing to shorten your life in order to live healthy? That's called the time trade-off. But it's directly related to a QALY. So meaning a quality adjusted life year means, what do you gain in healthy years? You don't want to gain unhealthy years. Nobody wants to do that. You don't want to have a treatment and live 10 years, in pain in a bed. That's not a QALY. A QALY would mean I get a treatment, and because of that, I live 2 extra years super healthy. That's a QALY, okay? And so that's what cost effectiveness does, is you're able to model the cost of something and the benefit. And the benefit in this case would be a QALY. The benefit can be money too. So there are different types of analyses. Cost-benefit analysis is all money. Okay? Cost effectiveness is actually a change in something that's not money, but it's not QALYs. So, I just put QALYs in there because that's the most common thing. But cost effectiveness is actually, let's say, a reduction in mortality. That's a benefit, right? A reduction in mortality. So if I introduce a new treatment or a new test in India, and it reduces mortality in patients with diabetes, that's cost effectiveness. But from what I just said, if it extends life, healthy years, that's called cost utility. So those are the different types of, tests, analyses that you can do. But they all kind of come under, everyone calls them cost effectiveness, but there are 3 different types, okay? So if you want to try and understand what we're doing here, if you look at the x-axis here, this is an increase as you go left to right in effectiveness. That means that your treatment is better going left to right. Going bottom to top on the y-axis is cost, money. So as you go up, it costs more to deliver a treatment. So, very intuitive. If you have a very cheap treatment, you're down here. And if that treatment is really good, you're here in this quadrant. And we call that dominant. Because, wow, if you could just drink mint tea and make cancer go away, that would be a dominant treatment. Because the cost of drinking mint tea is extremely cheap. And if it makes cancer go away, it's extremely effective. So you're here. That's dominant. Okay? Everybody gets that. Everyone loves that. Fantastic. The whole population benefits. Okay. What if it's cheap, you're drinking tea, and you're drinking a lot of that tea, but you're not quite sure if you're getting rid of breast cancer? So you're over here. And that would be questionable. Okay? And obviously, the higher the cost, the more it's a problem if you're over here, right? So if you're spending a lot of money for your mint tea, there's a problem there, okay? Now, if you're spending really a lot of money for your mint tea, and not sure if it's getting rid of your breast cancer, that's called excluded, okay? Those are treatments that should not exist. It's not worth it. Okay? Now we're getting to the last quadrant, which is a bit trickier, and all of the work we do in this area is in this quadrant, generally. So what if there's costs associated to it, but then it is effective? So that's where you're here, and that's the cost effectiveness quadrant, if you will. And so you can't say for sure where you're going to be in there until you do the math. And the reason for that is because if you have something very effective and relatively cheap, then it's going to be cost effective. If you have something that is effective but not great but very expensive, it's cost ineffective. And to finish this off, this yellow line here represents what we call the willingness to pay. The willingness that you're going to pay for that treatment. So inevitably, if you're over here, if that's the threshold for the willingness to pay, I'm not paying any more for that, that's it, that's the top, then this is going to determine, depending on where your treatment's going to be, is going to determine, on average, if your population is going to take on that treatment and whether it will be cost effective. Correct? So if you're up here, if you're above the line, most people will not be willing to pay for that treatment. That's the willingness to pay, okay? And willingness to pay is measured in qualities. Because how would I ask you how much you're willing to pay for a treatment that's going to, get rid of your cancer? Well, that's binary, isn't it? You're going to get rid of your cancer. But as you know, there's a risk when you have surgery for breast cancer. You go through chemo, all that stuff. You have to wait 5 years before you're cancer-free. And even then, it could come back. So it's not really binary, is it? So it's better to say, how much are you willing to pay, no matter what your disease, no matter what your illness, your pain, how much are you willing to pay for 1 year of perfect health? Perfect health. No pain, no problems, no disease. That is the willingness to pay, okay? So 1 year of perfect health. Okay, so let's look at cancer screening. So what we want to do, what we modeled in this study, was what if we use or introduce artificial intelligence into breast cancer screening in Costa Rica? That was the question. So there's going to be a lot of math, and I'm just going to skip through it because I don't want to kill you guys. But essentially, that's what we're trying to do. The big problem is in Costa Rica, there are not enough radiologists. I suspect it's exactly the same as in India. So meaning then, is actually what part of it talked about. Meaning that when you go for your cancer screening, you have to wait for somebody to read that scan and tell you, there's a lesion, please move to the next step, right, which is another test. And in Costa Rica, you're waiting on average longer than 6 months, and it can be up to 1.5 years. There's actually sometimes, they actually do cancer screening every year, and you're going to say, well, didn't you used to say every 2 years? And I did. But Costa Rica does it every year. So why do you think that is? Do you think that's better? I used to teach clinical, my PhD was in clinical epidemiology, so all this kind of stuff comes under epidemiology. So do you think it's better to screen women every year instead of every 2 years? Is it? Nope. Nope. It doesn't make any difference. That's why most countries do every 2 years. It's not cost effective. It's not any more cost effective to do it every year. And that's just because of the progression and the rate of cancer. So why are they doing it every year? Especially for a country that is middle-income country. Why would they spend that much more money, double the cost every year? Why do you think? You guys are going to relate to this in India. Why do you think they do that every year? Doesn't help them, costs them twice as much. Politics. The Minister of Health, when she came in, wanted to, make everyone think that, she was doing a good job and was, supporting women's health, and so that's what was decided. They were doing it every 2 years, and then when she came in, she said, no, fine, and it was just perspective. And it was not based on any science or medicine. It was all politics. So anyway, there you go. And I was going to say, that exists everywhere, but let me tell you, there's certain countries where it exists more, right? Okay, so the purpose, as I said, we're looking at introducing. So here's a case. So whenever you do cost effectiveness, I have a question already. Oh my God, go.
Because you said that it's done
Yes.
and here's a report you have to take 6 months.
Yes. Oh yeah, that's right. Oh, this is a good one. I forgot to even say that. That's awesome. So yes, so in Costa Rica, thank you. I didn't finish my story, did I? I got distracted. So they get screened every year, and sometimes they have to wait 6 months to a year and a half. So, believe it or not, some patients will receive a reading of the second or the subsequent mammogram before they ever even receive the previous one. Because I asked that too when I was down there. I was like, bro, that's not possible. Come on. Because it's all, right? It's in a list, right? You think it's ordered in a list. And radiologists are just going down the list. Nope. So whenever it gets performed, it's not centralized. So, it sits on somebody's list, and that's why it takes 6 months to a year and a half. And then, if the second one comes out before the first one, oh well. And that's the case, yeah. And they don't even know. They don't even know. Like the healthcare system doesn't even know. The patient knows. They're like, what? That's the one I just did last week. It doesn't make sense, right? So anyway, when you do cost effectiveness analysis, what you want to do is you want to compare cases. You want to compare your treatment, your hypothetical treatment, to what is currently being done. And so of course you give case examples so you can compare them. So Maria, asymptomatic, 56-year female, has a mammogram, right? Part of the screening process. No cancer risk factors, right? She's just lucky. The mammogram is not read by a radiologist due to the lack of the backlog, but actually she has early stage breast cancer. So at her next screening, the mammogram is read and reveals that she has advanced stage cancer. Oops, that's a problem. Carolina, on the other hand, same, 65-year-old female. Mammogram is reviewed immediately by AI. That's what we're trying to do. The report says early stage breast cancer. So do we take that as diagnosis? You physicians in the room? No, can't do that. So what do? We say, hey, let's send this immediately to a radiologist. It is read when it's read, but the purpose, of course, is to speed it up because it's put on top of their list. And then she gets treatment immediately or soon after, and obviously the outcome is better, right? Okay, so this is really messy, but this is essentially the flow chart of what we're proposing, okay? So you have screening at the top. On the left here is AI is the first reader. On the right is the conventional radiologist. They detect cancer or they don't detect cancer. AI, same thing, cancer, no cancer. If it goes to cancer, it goes to the radiologist. Everybody has to be confirmed by a biopsy, so no difference there. Then you get standard of care. Everybody gets standard of care. But then, of course, the difference is, when do you catch it? Early stage cancer or later stage cancer? If you catch that later stage cancer, the outcomes are poor, right? Early stage cancer, better. Okay. There we go. Now we're going into more graphs. So basically, these are the results, and you can't see it really. It's too small for you to see this. But essentially, what's called, it was undominated. Okay, so it's just your current. Actually, I can just show it the boxes here. So here, if you look at the numbers here, which as I said in the back, you're not going to be able to see. But essentially, what we're looking at here is a net monetary benefit. Okay, so this is what we're proposing. And if you look at the cost in what we're proposing versus the cost of the current system, all right, there's a reduction in costs. Okay, there's a reduction. And there's an increase of 86% QALYs. What? So QALYs, remember, is adjusted life years, which is a good thing. It's a benefit. So we've increased the QALYs, but no surprise, right? Because if we're catching the disease sooner, then people's quality of life improves because we extend their life. So that's QALYs. So not only overall do we reduce the cost, but we also extend life. So that results in what's called a net monetary benefit. And the net monetary benefit is a way for healthcare systems to get a dollar value. That's literally what it is. And so when we calculate it, we get a positive net monetary benefit, which is what you want. It's a benefit. It's a monetary benefit. If you adopt this treatment, right, it is a benefit to your healthcare system. Okay, so as I just said, the net monetary benefit, there's the math, don't worry about it. But inevitably, it takes into account your willingness to pay, of course, right? And did we give the numbers? I think we're at about 39,000 US. Okay, so like for Costa Rica, I think the willingness to pay is about $39,000 in US dollars. Okay, so that's how much you're willing to pay for 1 year of great health. I apologize, I don't know the willingness to pay in India. If you Google it, you may be able, or ChatGPT it, you may be able to tell me, but I didn't do it, and my apologies. But I'm going to guess it's ish the same. So that's why we're using the net monetary benefit. That is how healthcare systems are supposed to operate. Okay, I say supposed to because I'll be in Costa Rica. It's I'm working with them, and we're working on that, right? That the Ministry of Health is supposed to make decisions on how they weight and how they introduce treatments based on exactly this, doing this type of analysis, okay? And unfortunately, it's, as I said, there's political decisions that are over, doing more of it. Okay, so what's this slide? So these are called tornado graphs, and what it is many of you should have been thinking, wait a minute, this is all hypothetical. What if your algorithm is poop? Is it still cost beneficial, right? So that's what this is. These are sensitivity analyses. So essentially, what you should be thinking is, what if your algorithm is not accurate? Is it still cost effective? Well, no. But in our case, when we look at it, the blue line at the top, I think we light them up, yep. We went from, oh no, that's the other one. So, oh no, it's down here, yeah. We went from 0.7 to 1, right? So we would never implement an algorithm that's only 70% accurate. That's horrendous. But in this analysis, we check that. So if you are down here, 0.7, which is, we would never do, it is actually the net monetary benefit, interestingly, is still positive. What? right? Whereas if you are in the zone kind of where it would be effective, you're just crushing it, right? So you do this to just see, where does it shift, right? And so, for instance, here, this is the current system. What would you think you would shift in the current system? Because you don't have sensitivity, right? So what would you shift in the current system to see in effectiveness whether it's better? How could the current system be better? Shorter review time, right? That's the biggest problem. So if I was in the Ministry of Health in Costa Rica and I had this guy coming to me saying, hey, you should implement AI and blah blah blah, I would say, yeah, but I don't want to implement AI. So what do I need to do to make this guy go away? Oh, I know. Hire more radiologists so that my review time goes down. Correct? That is actually the correct solution, really. Right? But it's not possible because I don't have the money. But if you do look at that, that's what you're looking at here, probability of review within 6 months. So you're just saying if the probability of review is high, up to 1, which means 100%, then yeah, wow, that's the solution. Okay? So that's what sensitivity analysis is about. So the results in summary, AI is clearly, it's not just like, oh, just a minute. No. It's clearly cost effective, no matter the sensitivity, okay, as long as you're at a minimum of 80%, which I wouldn't even put an algorithm out at 80%, my God. Like, we're looking at 90% or above, right? If not, I stay home, right? Effectiveness of quality is higher than the current strategy, 86% higher, okay? The net monetary benefit is positive, if you want. In the long term, it does not exceed, it's $35,000, there you go, $35,000, okay, is the willingness to pay. The net monetary rate stays positive, sensitivity is maximizable, of course, because you can improve things. And then the ICERs, don't worry, we can talk about that later if you're interested. But bottom line is, it is cost effective, okay? And so, knowledge to action, AI screening can change practice, right? That's what we're looking at, by the reduction in delay, essentially, right? So what's the next step? You've got to validate it. You have to validate it, right? So the next step is to do a pilot program. So we go down there, we're currently setting this up. You do a study, right, where you have, you implement the changes, and you see how it works out, right, in a small scale study. And then if it works, and then you can convince the government. Working with governments is, wow, very interesting. Then it gets implemented. And so I'll tell you the biggest problem. So I'm an academic. I'm not in government, right? So I'm permitted to talk about this because I'm not in government. But I'll tell you, working with government, the biggest problem is you have to get people willing to listen to you. Very difficult to do. So when I first started all this kind of work, I used to get upset because people wouldn't listen to me. I'm like, come on, man, like seriously, I'm telling you this is good for you, right? And they don't listen. That was such a waste of my time, right? Because really, everybody has an agenda, everybody has their job, and so who's going to listen to me? Who am I, right? So it actually makes sense, right? So that's fine. Now I'm a patient guy, and I don't care how long. I've been working on this 2017 in Costa Rica. So I'm in no rush. But the next challenge is if I'm in no rush, during that period, the government changes. Like in Costa Rica, unfortunately, the Minister of Health gets fired and hired and fired and hired and fired and hired within the same government, and then you get a changeover of government, everybody gets fired. You're laughing because man, that's the way it works. And so I'm standing here, for years, and hi, and I have to say the same thing. Hi, every time. So it's very frustrating and it's very hard, but hey, it's our system. It's the way it works. Right? Okay, so I'll just to be mindful of time, I'm just going to touch on lung cancer because that's a big one for everybody. For us in Canada, lung cancer is not the #1 for men, but it is for you here in India, and it is for Costa Rica as well. And the reason for that is a variety, but probably a lot of it is lifestyle, okay, for lung cancer. That's affecting the difference between our countries. For us, it's prostate. Okay, so the biggest cancer for men is prostate. Okay, so I'm showing you the same graphs here for cost effectiveness analysis with the same numbers down here. And you can't see it because it's too small, my apologies. But if you look at the top line here, which is our solution versus the bottom, you can see, unfortunately, that the net monetary benefit is still negative, not a benefit. But I'll point out that the current system, the net monetary benefit is, let's say 1.5 million, okay? And our solution is less at not as bad, at 1.3. It doesn't matter because they're both negative. But what does that tell you about lung cancer? The outcomes are, yes. The challenge with lung cancer is all the patients die. It's extremely rare that no matter what you do, they're going to die. So the problem to a healthcare system when you're managing a healthcare system for an entire population, it's not cost effective to treat lung cancer. I hate to say it, but it's just a mathematical fact, right? That you're going to spend more money treating and dealing with lung cancer no matter what you do, and it costs the healthcare system a lot of money. So ideally, you just wouldn't treat lung cancer. But you can't do that, right? That's ridiculous, right? You can't do that. But seriously, math-wise, you would probably not, okay, I'm going to be blunt too. I'm a statistician, right? So I'm going to be blunt. You have what's called scarcity of dollars, right? That's a term used in cost effectiveness analysis. The scarcity of dollars means you only have so much money to take care of the health of your population in your country. There's a finite number of dollars. So if let's say you didn't, consider mom, dad, your family, your friends, you're very objective. Well, you're going to want to spend your money where you're going to have the biggest impact on the health of your community. So what you don't want to do is spend a lot of money on something that affects, let's say, less people, so hemophilia. There's an example where really you shouldn't treat hemophilia because the cost of it is just, wow, expensive to the healthcare system for very, very few people. So it's not cost effective to treat hemophilia. That's a fact. In this case, lung cancer is a little bit the same way. It's not that there aren't many people that get lung cancer. Unfortunately, a lot of people get lung cancer. The only thing is, by the time you get lung cancer, you die really quick. Like, a couple of years, you're done. And so to spend all the money to treat and to take care of lung cancer is just not cost effective for society. So that's why it is so difficult to make these decisions. Because of course you're going to, treat lung cancer. Of course you are, right? And the reason for that is because that's what your population wants you to do. You have to be mindful of what everybody wants done with their money, their taxpayers' dollars. So this type of analysis informs ministries of health who make those decisions. Okay? So in this case, it would be a hard sell for me to come in and say, let's introduce artificial intelligence into screening, or at least trying to shorten the time for the diagnosis of lung cancer. Because even if we do help it a bit, it's still costly to the system. And so then it's going to be very difficult for the government to say, well, we have to spend a little bit more to put in your AI, and in return, we're going to get maybe a few people that are happier. That's still a problem for them because they're spending too much money. Okay? I know it's sad to speak that way, but it is. So for instance, QALYs don't mean money, which is a problem. So meaning cost-benefit analysis very often is what's used in companies and governments. because they only have so much money to spend. So even though many people will say, "Oh, wait a minute, you're going to not only save a little money, but you're also going to extend life, so people are really happy." Unfortunately, very often that's not, that's just not a driver, right? So you have to absolutely show them that by extending life, that person is more productive in society and therefore benefits society and in return pays more taxes for a longer period of time. See how like, wow, this kind of analysis becomes? That you literally have to pay, calculate the extra money that these people that you're extending their life are going to contribute back to the pool, right? So it's a very interesting area. And that's why I'm sharing it with you. And AI, let's come back to AI, can help this, all right? So that's definitely where AI can play a role, is by changing the cost effectiveness of the delivery of healthcare. This was just a sense, this was all just showing you that it's just not, we can't do it. Yeah, it's just not cost effective no matter the sensitivity rate, no matter how amazing you make it. It can't do it because of the cost, right? Even though we show an improvement of 5 years quality of life for patients. That's what we show. Wow, that's cool, right? But the net monetary benefit is negative. Okay, no matter how much of a gain you're showing, it's just not cost effective. Right? Actually, so Giancarlo is my partner in Costa Rica, and he's a GP in Costa Rica. That's about it for cost effectiveness. Was that a little too happy? No, it wasn't bad. Not bad. Not bad. You can lie. You can lie. Make me happy. Yeah, it's great. Okay. Any questions? Who wants to be a cost effectiveness statistician? Have I changed? Is that it? You're not going to go into engineering? Changing your mind? Maybe not. But it's a very interesting area. It really is. It's worth the effort to just at least poke around a little bit. And the reason for it is because of everything we've been talking about so far this week. And that is, why are you doing what you're doing? So why would you be implementing the algorithm or the solution, the software, the app? Why would you be implementing it? How does it impact the society at large? Right? Because I'll tell you for sure, if you want, as a company, let's say, you start up your own company, you're all excited, you've got a medical device, or you have some software, software is a medical device, and you would like that to be implemented by the government. That's everybody's dream, right? I mean, selling is one thing, of course, but then what's your market? Right? What's your market in India? It would be terrible. In Canada, it's not bad. But in India, it's going to be terrible. And why is that? Because you have, compared to the entire population, how much of that population has a lot of money? Not much, correct? And so when you're selling a medical device, you're selling to that population. You're not selling to the vast majority. You're selling to a very small, finite part of the market. So anybody who develops a startup or a medical device, ultimately what they really want is to be to sell privately, of course, but also to be adopted by the government. Of course, because then the government is just paying for your product to be distributed and used by everybody, right? So I'll tell you right now, the only way, I don't know about India, but I suspect it's the same way. The only way you're going to get your product approved by the government is you have to go through it. Absolutely 100%. If you do not show cost benefit or cost effectiveness of your product to the government, they will not adopt it. Guaranteed 100%. Just telling you right now. Okay? And I'll tell you how it works in Canada is they'll do it themselves. So even they really appreciate it if you do it yourself. They say, "Ooh, thank you very much," and then they just check it, But if you don't, because that's not your area of expertise, they will perform, and then you wait while they do it. They'll perform that analysis, and they will decide then to implement it. That's literally how it works. Yeah. Yes. Right. So the United States has two, like here, has private and public, and the public is just so small, right? Medicare, Medicaid is a small proportion. But yes, absolutely. So it's still valuable in a private setting as well. Okay, because even within a private setting, just like in the quadrant I was showing you, right? As the cost goes up, then your market gets smaller. So as a company, you're going to want to do the same thing and show how cost effective it is, because in medicine, you need adoption. And adoption comes with medical professionals aligning with you and saying, yep, I like that. That's a good product. And I'm going to encourage the use of it. So if you don't get that, you're not going to sell. And so you need it. So it actually is used as well, for sure, in the private industry. Just depends on the product. If it really is a convenience product that you're willing to pay a lot of money for very little effectiveness, because you have tons of cash, why not? Then, those ones you don't waste your time. But for the ones that are just, kind of, close to the willingness to pay and stuff like that, then cost effectiveness analysis is crucial. And actually in companies, cost effectiveness analysis used to come under math, right? It used to be the statisticians in the dungeon, in the basement, that you only called on sometimes, hey, can you do it? And no one pays attention to them. But it's changed now. So cost effectiveness analysis actually in many companies has moved to marketing. So interestingly, the statisticians, and they moved out of the basement, and they now collaborate in, or are part of, embedded in marketing. And the reason for that is exactly what we just said. As a company, it's important to market the product, to say, hey, I'm going to extend quality of life for you, and I've shown this if you use my product. So it's marketing. Yes, sir. Yeah.
I think the attendees here are having impression probably they can develop a software for all conditions. For example, breast cancer, which is quite common here. But coming to Costa Rica or Canada or America, we have a different system in the sense we don't need an EMI to integrate our solutions. There's plenty of radiology. One mammogram done. If we don't have a person, we can always send the image to a person who can. There are consultants available to do this sort of stuff. So I think it is counterproductive for the people to have something like that and try to say they know it's fine. Because they have, it comes to 300 rupees, the consultant fee. Whereas you try to build your software and do it, it's not profitable for you. So we have a perspective definitely from what we have experienced in Costa Rica. I think the scale, again there are some instances where the American Rapid this association approach, colonoscopy and picking of polyps. Is it really beneficial after doing things? Because identifying a polyp is okay. But the problem is how many of those polyps are going to be malignant or eventually can be prevented. So again, we are skeptical. And the data sets which we use there, is it applicable to this society? And if the same thing is used here, will there be a bias introduced? Because there are bias in the system. So when we program it, the data we should feed, the outcome will
Yep. So you bring up an excellent point, and you're absolutely right. And we bump up against that in any country we go to, and that's one of the biggest problems, and we're addressing it in Costa Rica, and that is, where's your algorithm trained? Why was it trained? What was its purpose? And does it apply to the country you're in? Correct? I mean, you're absolutely right. And so first, to answer for all of you engineers, the first thing is your algorithm needs to be retrained in local data. So that's a no-brainer, all right? If you don't do it, then the generalizability is not as good. And as you know, most algorithms are trained on Chinese and North American data, period. Today, it's changing, but today. So in India, does it apply in India? Well, no, I mean, yeah, it's gonna work, but will it work as well? No. So definitely, if you come to India with software, you're going to have to show that you've retrained your algorithm specifically for the Indian population. So that's the first thing. You're absolutely right. So then, and then the biases. You're absolutely right. So meaning, where you've created the algorithm, where you've created the software, does it apply to the the new society you're in? Absolutely. Like, is it relevant? Right. So it's the relevance of it. Absolutely. That's another challenge. In terms of private versus public, so this definitely is supportive of public. You're right. In India, its majority is private, and because of that, it's competitive, which is very true. And so meaning that you could take your test and have it interpreted fairly easily, correct? Because the competition has kept the costs reasonably relevant. And so you're right. You're absolutely right. So that would be an additional challenge for you here in India, is how could you use AI in order to improve the system that you're in here. I still think it's possible, because you would just have to retweak the problem, right? So in our case, it's a lengthy wait for a radiologist to read. Not a problem here, right? So you're going to be able to get that time. So then it's still a cost, right? So then the question then is, how could you could still look at AI improving the system, but you're absolutely right. It's going to be different than what's going on in Costa Rica, right? I haven't done projects in India, so my apologies, I don't know, right? But I'm showing you an example of what we've done, which could be applicable here, but differently, right? So you're absolutely right. Yeah, that's a very good point. And you have to be mindful of that. Is what's the question you're trying to answer? What's the problem you're addressing? But there's usually always a solution, and I would be very surprised if AI is not going to be assistive even in this system, right? So I'll tell you right away, for one, standardization. So you're right, lots of radiologists. Are they all good? That's the problem, right? Because unfortunately, private systems encourage money, right? It's for profit. So I'm not saying it's all bad, don't get me wrong, but if you don't have very much money and you want your scan read, where are you going to go? Probably to the cheapest, correct? So what does that mean? Why are some radiologists not charging as much as others? There's something you can think of, right? And so that's where AI would be assistive, right? Because you'd have, you provide a tool to all radiologists willing to use it. That's going to standardize it, right? So there's an area that you could address instead of addressing the public. Now there's still a need for public. There's still a need for public in India, and you're over 1 billion in population. So that's, no matter what the percentage of the population is, that's a lot of people. So there still certainly can be some. I mean, okay, if I was doing work here in India, that's what I would target immediately. And you'd say, why would you do that? Because there's this huge inequity, and to provide care to patients that don't have access just makes sense. It makes intuitive sense. No matter what your system is, even if it's majority private versus public, by targeting something in the public, you're still going to draw a lot of attention in the private, right? You're actually going to threaten the private, right? Because if you put a solution in place that reduces costs for screening or whatever, and then all of these private systems have hired like 15 radiologists, and then they realize, well, we don't need 15 radiologists. Now we only need 5 with a tool. Then you're redistributing the money, essentially. So their costs of running their private business, I mean, I would hope they're not just going to, pocket the profits. Yeah, maybe. But what they're going to try, hopefully do, is redistribute the money that they're spending on other things and improve the system, right? That's the hope, of course. Anyway, we could talk about this for weeks. Any questions? Any questions on that? No, we're good? Awesome. Thank you. I think, right? Like we're good, right? Yeah. No, I don't. No, I think that was. It. Because what time's lunch? Oh, 1 o'clock. Wow, that's only in 8 minutes. So if I hadn't done the presentation, I don't think I could squeeze it into 8 minutes. So yeah, no, I mean, we can. I'm happy to discuss further. It's always a very controversial topic for obvious reasons, but it's kind of an important driver, right? for tech anyway, of why you're doing it and how you can improve, for your clients essentially, whether it be for profit or not. So, yeah, we'll let you go early. Thank you.